This recorded lecture will go over Chapter 18, Care of Patients with Hypertension and Peripheral Vascular Disease, in the MedSurg textbook. Hypertension is defined as persistently high blood pressure. This means a systolic pressure that is equal to or greater than 130 and a diastolic pressure equal to or greater than 85. This should be taken at least twice and averaged on 2 separate occasions 2 weeks apart. The diastolic pressure is the focus of treatment. Hypertensive individuals will typically die of long-term damage to the end organs or target organs. Target organs include damage to the brain, heart, and kidneys. Immediate causes of death related to high blood pressure include cerebral hemorrhage and heart failure. Hypertension is classified as primary or secondary. The etiology of primary hypertension is believed to be related to genetic and environmental causes, whereas secondary hypertension is caused by multiple other conditions, including renal, vascular, and endocrine disorders. In 5 to 8% of patients, the hypertension is secondary to another disorder. Acute stress, excessive alcohol intake, sickle cell disease, arteriosclerosis, coarctation of the aorta, eclampsia of pregnancy, renal disorders, endocrine disorders, and neurologic disorders are all examples of secondary causes. If the underlying disorder can be detected and treated successfully, the problem of secondary hypertension can be eliminated or more easily controlled. If no underlying disease can be identified as elevating the patient's blood pressure, then they are considered to have primary hypertension. A moderate reduction of salt intake has been effective in lowering the blood pressure of some patients with mild to moderate hypertension. The rising incidence of childhood obesity has resulted in an increase in the incidence of hypertension. Blood pressure equals the amount of blood pumped out of the heart or cardiac output multiplied by the systemic vascular resistance. If the diameter of blood vessels become smaller because of atherosclerosis or vasoconstriction, the blood pressure will increase with the effort to force the blood through a smaller opening. On page 407, you can see a concept map that has a really great layout of the pathophysiology of hypertension. So if you like learning from concept maps, maybe take a look at that. Also on page 407, we have table 18.2, listing the non-modifiable and modifiable risk factors for primary hypertension. Hypertension has been called the silent killer because in the early stages, it will not cause discomfort or any other subjective signs and symptoms to indicate its presence. Signs will typically only appear in the later stages when damage has already been done to target organs, including the kidneys, brain, eyes, and heart. Patients with symptoms may complain of headache, dizziness, blurred vision, blackouts, irritability, angina, dyspnea, or fatigue. Hypertensive patients will develop coronary heart disease at a rate 2 to 3 times faster than that of people with normal blood pressure. Diagnosis is based on blood pressure readings on at least 2 occasions that occur 2 weeks apart. An EKG, echocardiogram, and cardiac stress test can be ordered to determine whether any damage has been done to the heart muscle. The goals of treatment include reduction of high blood pressure and long-term control to decrease the risk of stroke, heart attack, loss of vision, and kidney disease. The target is to control the blood pressure at or below 120/80. Treatment is individualized using a stepped care approach. Sodium should be kept to less than 2,400 milligrams per day with the DASH eating plan. Aerobic exercise of 30 to 45 minutes on most days of the week is recommended. If blood pressure reaches stage 1, a diuretic or antihypertensive drug will be prescribed. In stage 2, all of the previous measures continue and other medications are added. Patients with more severe hypertension often require more than 2 drugs to attain control. If a potassium wasting diuretic is prescribed, the patient should be taught to increase their dietary potassium intake. The drugs prescribed to reduce blood pressure will work by decreasing the blood volume, the cardiac output, or peripheral resistance. Medications used to treat hypertension reverse or block conditions that will cause elevated blood pressure. The blood pressure of older adult patients who are taking antihypertensive medications should be measured while they are sitting and when standing. Many of these medications can cause orthostatic hypotension. On page 408, we can see some safety measures to prevent falls for patients with orthostatic hypotension. It's very important to rise slowly from a lying to a sitting position. Instruct the patient not to hold their breath while they rise. Sit for 1 full minute before standing, and then stand slowly while holding on to a stable object. They should stand for 1 full minute before they walk. While the patient is seated, they should flex and rotate the feet several times before they attempt to stand. Then plant the feet firmly on the floor prior to standing. Assess your patients receiving antihypertensives for any dizziness, confusion, syncope, restlessness, and drowsiness, all of which can indicate hypotension. Hypertensive emergency is a life-threatening situation in which the blood pressure rises higher than 180/120, and there's an indication of target organ damage. Symptoms can include severe headache, blurred vision, seizures, nausea, and change in level of consciousness. The patient will be placed in the ICU and treated with IV drugs, including IV nipride, cardine, nitroglycerin, labetalol, all designed to lower the blood pressure. Medication will be adjusted to reduce the pressure slowly. This is to prevent any renal, cerebral, or coronary ischemia. Hypertensive urgency occurs when the blood pressure rises to 180/110, but there are no symptoms of target organ damage. This is more common than hypertensive emergency. The patient will typically be observed in the ER and then treated with oral medication. They are directed to follow up with their primary care provider. Nursing interventions consist of assisting the patient to make necessary lifestyle changes that can help control the blood pressure and slow any atherosclerosis. Diet changes are often the most difficult part for the patient. Sources of hidden sodium should be identified, and the patient must be taught how to read food labels. Patients who need to increase their potassium intake should be taught to include citrus fruits and juices, bananas, dried beans, tomatoes, and potatoes in their diet. Weight loss is the most important lifestyle change for obese patients. The goal is a weight that is within 15% of ideal body weight. If caffeine restriction is recommended, teach the patient to gradually decrease their caffeine consumption so that they will not experience withdrawal symptoms, including headache and nervousness. Stopping smoking or the use of smokeless tobacco products can also be a difficult task for many patients. An exercise program that fits the patient's personality, ability, and preference should be designed. The object is to work on something that the patient will continue to do for the rest of their lives. Even a moderate weight loss of 7 to 12 pounds can reduce blood pressure. Positive reinforcement should be given for even small amounts of weight loss. Stress reduction techniques will also require an evaluation of lifestyle. Help the patient determine where their stressors are and what can be done practically to manage them. Lifetime compliance with diet, exercise, stress reduction, and medication plans can be difficult for most patients. Instruct patients on how to monitor their blood pressure at home and engage them within their care to track the effectiveness of treatment. For evaluation, consistent maintenance of blood pressure within prescribed limits is a primary indicator of effectiveness of disease management. The patient's compliance with the management of hypertension is critical to preventing or minimizing any complications of this disease process. Arteriosclerosis is the hardening of the arteries. This is a general term for a variety of arterial changes. Arteriosclerosis occurs with aging as degenerative changes occur in the small arteries and arterioles. This disorder is characterized by thickening of the artery walls that progresses to hardening as calcium deposits form. This can lead to ischemia and necrosis in various tissues. Atherosclerosis is another form of artery narrowing. Lipids are deposited within the vessel walls and combine with cells, fibrin, and cell debris to form plaque. The plaque will grow and extend into the lumen of the artery, where inflammation or erosion can cause the plaque to be exposed to the blood. This will trigger clotting and subsequent blocking of the vessel by the clot. Diabetes mellitus, particularly when uncontrolled, will speed up the development of arteriosclerosis and atherosclerosis. Hypertension is a major factor in arteriosclerosis. Peripheral vascular disease, or PVD, involves the narrowing or obstruction of peripheral blood vessels and loss of function. These vessels can be in the arms, neck, abdomen, or lower extremities. Other causes of peripheral vascular problems would include spasm of the smooth muscles in the artery walls, structural deficits in the arteries, trauma, or embolus that will cause occlusion. Peripheral venous problems can often be caused by defective valvular function and formation of a venous thrombosis or blood clots. These can also be accompanied by thrombophlebitis. Prevention of PVD is focused on decreasing atherosclerosis and arteriosclerosis, controlling diabetes, controlling hypertension, and preventing smoking. This picture can be seen on page 415, showing the peripheral vascular system in the lower extremities. The most common etiology of peripheral arterial disease, or PAD, is atherosclerosis. Restriction of arterial blood flow can cause arterial ulcers. Cessation of blood flow in the artery will lead to ischemia and tissue death. PAD can be acute or chronic. PAD can occur in any peripheral artery, but it frequently occurs in the carotid arteries. Signs and symptoms of PAD of the lower extremities would include intermittent claudication, pain at rest, tightening pressure in the calves or buttocks, and ischemic changes. Blood pressure in the extremity affected by PAD will be lower. This can be identified by obtaining an ankle brachial index, or ABI. Patients with PAD have pallor in the affected extremity when the leg is elevated, and rubor when the leg is dependent. The skin can appear tight and shiny. Hair is usually absent on the affected extremity, and the toenails are thickened. Pulses are diminished or absent. Wounds on the lower leg will be difficult to heal. If severe ischemia occurs due to occlusion of arterial blood flow, tissue distal to the occlusion blanches, becomes cold, hurts, or eventually becomes numb as necrosis occurs. Arterial ulcers with a sharp edge and a pale base can form, and they are quite painful. These ulcers will be very slow and difficult to heal. The toes and foot are most often affected by cellulitis. An arterial thrombus can occur as a vessel is narrowed by atherosclerosis. If the clot breaks loose and travels, it becomes an arterial embolus and causes the acute occlusion of an artery distal to the plaque. Signs and symptoms of embolus on thrombus occlusion of an extremity artery are the 5 P's: pain, pulselessness, pallor, paresthesia, and paralysis. Acute arterial occlusion can be treated with percutaneous intravascular procedures. Thrombolytic therapy may be given directly into the clot within the artery if it can't be removed successfully. Diagnosis of PAD is made using the ABI. Radiographic and ultrasound procedures can also be performed. The best treatment for arterial occlusive disease is regular exercise. A regular walking program will result in substantial improvement. Smoking cessation is also a key factor in improvement of peripheral arterial occlusive disease. The goal of treatment of PAD is directed towards increasing the blood flow through the peripheral arteries and decreasing the risk of clot formation in the vessels. Antiplatelet agents and platelet inhibitors can be used alone or in combination with other drugs. Aspirin is most commonly used antiplatelet agent. It will prevent the aggregation of platelets within the arteries. Platelet inhibitors, such as Plavix, can be prescribed. Patients experiencing intermittent claudication may achieve relief of symptoms when prescribed Trental or Pletol. These drugs can increase blood flow by inhibiting clot formation in the vessels. Percutaneous transluminoangioplasty, or PTA, can be performed to open an artery and reduce claudication symptoms and improve extremity perfusion. A catheter is introduced into the artery, and when the proper spot is reached, a balloon is inflated multiple times to dilate the vessel. This promotes better blood flow. A metal or mesh stent can be placed to prevent the narrowing or closure of the artery. Arthrectomy can be done by several techniques: removing the plaque by laser, cutting, or abrading. By removing the plaque, the diameter of the vessel is then enlarged, allowing for increased blood flow. Stenting is typically performed to maintain vessel patency. Interventional procedures can prevent the need for open surgical intervention. A patient with PAD, a normal ABI, and complaints of claudication would be a great candidate for PTA. Surgical or interventional treatment of PAD is a palliative measure only. It will not cure the disease, and it will not halt the atherosclerotic process. It can, however, relieve ischemic pain, help prevent amputation, and add years to a patient's life. An aortoiliac bypass or femoropopliteal bypass is performed to correct arterial occlusion of the leg to prevent the need for amputation. Postoperative care is the same for other operative procedures, but it does include careful assessment of pulses distal to the graft to detect a thrombus formation. Blood pressure management is extremely important to maintain blood flow in the graft. A hyperbaric oxygen chamber can also be used for patients with severely compromised circulation to a lower extremity. This is to increase tissue oxygen and prevent amputation. When assessing, perform a physical assessment of the patient's affected extremity at least every 4 hours or per facility protocol. The feet should be assessed for warmth, paresthesia, pain, and pulses. Major nursing role is early detection and prevention of complications. The major nursing care goals for patients with PAD include maintaining arterial blood flow to the lower extremities, protecting tissues from further injury from pressure and constriction of the blood, and preventing wound infection. We can encourage blood flow by keeping the patient and their environment warm. Constricting clothing should be avoided, and the bed should not be raised at the knees to prevent any added pressure on the back of the knees and further occlusion of blood flow. The lower extremities should be positioned below the heart level to facilitate arterial blood flow. The legs should only be elevated if edema is impeding circulation. Encouraging exercise is especially beneficial to patients with decreased blood flow. Tobacco use, especially smoking, will contribute to PVD due to the vasoconstrictive effect of nicotine. Referral to a smoking cessation program, providing a support group of information, and teaching regarding the adverse effects of smoking may have all been attempted on previous occasions, but know that each encounter is an opportunity for the patient to be receptive to new information. Evaluation of the effectiveness of the plan of care would involve assessing changes in the peripheral pulses and skin integrity. You should evaluate the patient's ability to meet established goals and revise the plan as needed. Aneurysms are outpouchings of the wall of an artery resulting from a structural defect in the layers of the arterial wall. These typically occur in a weakened area of a blood vessel. Aneurysms are usually the result of plaque formation, genetic predisposition, or hypertension. Long-term hypertension and smoking are risk factors, particularly in men. Congenital malformations, diabetes mellitus, and hyperlipidemia will all predispose the patient to various types of aneurysm. However, atherosclerosis and hypertension are believed to be the major factors within their development. An aneurysm can occur along any artery. Once an aneurysm develops, it will continue to grow larger. Aneurysms can eventually rupture if they're not repaired. Aortic dissection of the medial layer of the arterial wall can occur. This will cause bleeding between the layers of the wall and increase pressure on the surrounding structures. Dissection occurs more frequently than aneurysm, particularly in men who are hypertensive. Although dissection and aneurysm are two different problems, they can occur together and they do have similar risk factors. Aneurysms often cause no obvious symptoms. Patients with an abdominal aortic aneurysm, or AAA, may report back pain or a feeling of pressure. They may also have a visible pulsation of their abdomen. Diagnosis of aneurysms is difficult due to the lack of symptoms during formation. Physical assessment and screening of patients with a family history can sometimes be the best means of early detection. The presence of an aneurysm can be verified by chest or abdominal X-ray, ultrasound, MRI, or CT scans. AAA rupture is a medical emergency. About 65% of patients with a ruptured AAA will die before they reach the hospital. Aortic dissection will usually cause abrupt, excruciating pain. This pain will then radiate to the back, chest, and abdomen or the extremities. If an aortic aneurysm is detected early, it can typically be surgically repaired before it dissects or ruptures. The size and the location of the aneurysm will guide the need for any surgical intervention. Thoracic and abdominal aneurysms will not warrant any surgical intervention until the risk of rupture is higher than the risk of surgery. The patient is evaluated every few months with ultrasound tracking to see the size of the aneurysm. Surgery for aortic aneurysm would involve replacing the area of the vessel wall that is weakened with a graft or inserting a stent graft into the vessel. The graft will provide support to the vessel wall and allow the blood flow through the stent, therefore reducing pressures on the vessel wall. The aneurysm can then be monitored more frequently. Careful physical assessment will be needed to detect the presence of an aneurysm. Changes in peripheral pulses should be noted. Clots from the aneurysm can embolize and affect perfusion. The main goal for a patient with an aneurysm is the prevention of rupture. Rupture of an aneurysm is a medical emergency, and it will cause rapid hypovolemic shock, which can lead to death. The patient should be taught signs and symptoms that need to be reported to the healthcare provider. The surgical procedure and nursing care plan will depend on the location of the aneurysm and the procedure performed. The main difference between a thoracotomy or abdominal surgery and other types of thoracic and abdominal surgeries is that you also need to carefully assess pulses and function distal to the repair site. Renal function needs to be watched closely because blood flow to the kidneys is briefly cut off when the aorta is clamped for surgical repair due to an abdominal aneurysm. Coughing is not encouraged, but it should occur. Coughing is not encouraged, but if it should occur, the incision must be splinted with a pillow or folded blanket. Auscultate the abdomen every shift for the return of bowel sounds. A patient undergoing thoracic aorta aneurysm repair will have chest surgery that uses a cardiopulmonary bypass machine. The care is the same for any other chest surgery patients. These patients will be especially at risk for atelectasis and pneumonia. Cardiac dysrhythmias can also be a problem, depending on the location of the repair. Observation for bleeding from the procedure site is a priority assessment. When atherosclerosis has narrowed the carotid arteries leading to the brain, the signs and symptoms will include a carotid bruit, confusion, transient vision loss, fainting, extremity weakness or paralysis, or other stroke-like signs of decreased blood flow to the brain. The condition will be treated by carotid endarterectomy or carotid artery angioplasty with stenting. The most benefit from surgery will be attained if the surgery is performed when the artery has been more than 70% stenosed. The goal of both procedures is to prevent the occurrence of stroke. Specific postoperative care for endarterectomy would include assessing the patient for signs of bleeding, for pressure from hematoma on the trachea, and for neurologic problems caused by thrombosis or embolus. Neurologic signs should be monitored every 2 to 4 hours. If surgery is not indicated, the patient will be taught how to maintain adequate hydration and to comply with drug therapy for hypertension, diabetes, and hyperlipidemia if applicable. Thromboangiitis obliterans, or Buerger disease, is one of the approximately 20 disorders that can cause inflammation in blood vessels. Thromboangiitis obliterans is a primary condition not caused by atherosclerosis. Instead, it involves inflammation and thickening of small and medium-sized arteries. Occlusion of the vessels in the hands and feet will typically be noted first. Moderate to heavy cigarette smoking is directly linked to the progression of this disease. The signs and symptoms include numbness and tingling of the toes or fingers in cold weather, pain in the feet, and intermittent claudication that progressively becomes more severe. Ulcerations and gangrene can occur. Diagnosis will be made through patient history, symptoms, and angiography. Cessation of smoking is the single most important treatment factor. The most important nursing role is patient teaching and reinforcement of the need for smoking cessation. The etiology of Raynaud's disease is unknown. Raynaud's disease is characterized by spasm of the arteries in the upper and lower extremities. The body has an exaggerated response to cold and stress. This results in bilateral vasospasm. This disease occurs most commonly in young women, and it typically affects the fingers and toes. Blood vessels normally constrict in a cold environment. However, with Raynaud disease, this process is excessive. The affected body part will change color. When the spasm stops, there is typically burning, pain, and throbbing. In about 10% of those affected, the disease will progress to the point at which ischemia from arterial spasm is so severe that gangrene occurs and amputation is necessary. Signs and symptoms of Raynaud disease include the following. Fingers and toes may display a series of color changes from white to blue to red. These changes can be evident on the dorsal surface of the hands and feet. The patient may experience numbness or a prickly sensation on warming and the relief of stress. There may be decreased sensory perception. Edema may be present, and discomfort may occur in the extremity. Diagnosis of Raynaud disease is usually made by evaluation of patient symptoms. Medical therapy consists of stress control, avoidance of exposure to cold, and smoking cessation. The major nursing intervention for Raynaud disease is teaching the patient to protect their extremities and prevent any injury. The patient should be taught to dress warmly when in cold environments. Hat, gloves, and warm socks should be worn. Teach the patient to avoid cold temperatures when possible, to manage stress, and to stop tobacco use. Caffeine intake should also be limited. Superficial thrombophlebitis that occurs in a patient receiving IV therapy can be caused by chemical or mechanical irritation of the vessel. If this is not identified and treated, bacteremia can occur, resulting in septic thrombophlebitis. Superficial thrombophlebitis can occur spontaneously or as a complication of medical or surgical interventions and will typically occur in the lower extremities. Redness and tenderness along the course of the vein, accompanied by swelling, are the typical presenting symptoms. An ultrasound demonstrating thickened, inflamed, and non-compressible veins will confirm this diagnosis. Treatment for thrombophlebitis will depend on the severity of the condition. If the IV is implicated as the cause, the IV catheter site should be changed to a new location. For mild tender areas, treatment with analgesics like NSAIDs is typically adequate. More severe thrombophlebitis can be treated with elevation and heat, but the treatment is primarily symptomatic. If an infection is present, antibiotics will be given. Deep vein thrombosis, or DVT, occurs most commonly in the iliac and femoral veins, but upper extremity DVT accounts for 5 to 10% of all incidences. DVT prophylaxis is recommended for all hospitalized patients. Classic signs and symptoms include pain, swelling, and redness, but many patients can be asymptomatic. Upper extremity DVT is more likely to present with pain, swelling, and arm fatigue. People who are immobile for a long time are susceptible to DVT. Immobility with the legs dependent in a car or airplane for long periods of time will also promote venous stasis. Inflammation of the vessel will lead to aggregation of blood components at the site of inflammation. A clot forms at the inflammation site, leading to obstruction of blood flow. If not treated, the clot can become an embolus that can travel from the legs to the lungs, resulting in a pulmonary embolus. Smoking, female hormone replacement, estrogen-based contraceptives, corticosteroids, and various blood disorders are contributing factors to hypercoagulability. Obesity and dehydration will also contribute to increased coagulability. Patients particularly at risk for DVT include those having orthopedic surgery, those who smoke, those with diabetes, lung disease, blood disorders, PVD, sepsis, or cancer. When a pulmonary embolus is suspected, place the patient in a high Fowler's position, provide oxygen and reassurance. Notify the healthcare provider and stay with the patient. Patients are encouraged to stay off their feet and to elevate their legs. Support stockings should be worn after the acute phase. Inpatient medical treatment for DVT typically consists of IV heparin. Low molecular weight heparin, such as Lovenox by injection, can be used for inpatient management, and it is increasingly being used for outpatient management. After initial IV or sub-Q injection of anticoagulation treatment, an oral anticoagulant is started, typically Coumadin, Xarelto, Lixania, Pradaxa, Beviexa, or Eliquis. The anticoagulation will then be continued for 3 to 12 months. Anticoagulants will not dissolve the clot, but they can prevent new ones. The body will dissolve the clot on its own over time. Thrombolytic therapy can be used to dissolve the thrombus if vessel obstruction is severe. The agents used are the same as those listed for arterial thrombolysis. Sequential compression devices, or SCDs, can be prescribed, or compression stockings can be fitted for daily use. Compression stockings are removed only for bathing, and they should be changed and laundered daily. Ambulation, as soon as it is not prohibited by pain and swelling, is recommended. There is no evidence that ambulation will dislodge a DVT and cause a pulmonary embolus, as it has been believed for many years. If a patient is considered at risk for further embolus formation due to DVT and is not a candidate for anticoagulation, a vena cava filter may be inserted. The device is placed in the inferior vena cava, or IVC, below the kidneys to prevent pulmonary emboli. IVC filters come in all different shapes and configurations, but each one does the same thing. Post-thrombotic syndrome is a potential complication for 50% of patients with DVT. While the body is dissolving the clot, there is continued inflammation at the site. This will cause permanent damage in the vessel and can lead to venous insufficiency. Thrombolytic therapy delivered directly into the clot, percutaneous thrombectomy, angioplasty, and stenting are all being examined with the goal of preventing PTS. Heparin-induced thrombocytopenia can occur when unfractioned or low molecular weight heparin is used for several days to weeks. This is heralded by a sudden decrease in platelet count. If HIT occurs, heparin administration must be stopped. Assessment. Assess patients at risk for DVT every shift for signs and symptoms. Assessment should include observation of the extremity for any asymmetric size, areas of warmth and tenderness over a vein, calf pain or tenderness, pitting edema of the affected extremity, measurement of calf circumference, body temperature greater than 100.4 degrees Fahrenheit. Nursing management of a patient with thrombophlebitis from DVT would include assessment and documentation of the color, warmth, circumference, and pulses of the affected extremity. Components of a teaching plan may include the avoidance of sitting for long periods of time with the legs down, avoidance of standing in one place for long periods of time, management with NSAIDs, the application of compression stockings, and preventative measures. Early ambulation postoperatively can help promote circulation and reduce the risk of clot formation. Venous thrombosis occurs fairly commonly during long plane flights or car trips. Staying well hydrated, exercising the leg and calf muscles frequently during the trip, and walking every 1 to 2 hours when possible can help prevent clots from occurring. Decrease in leg circumference and adequate blood flow to the extremity, as evidenced by color, warmth, and lack of edema, will indicate that interventions for DVT are working. Decreased redness, swelling, and pain can also indicate resolution of thrombophlebitis. Varicose veins are enlarged and tortuous veins that are distorted in shape by the accumulations of pooled blood. Veins that develop varicosities have incompetent valves that allow the reflux of blood from deep to the superficial veins. Varicosities typically occur in the saphenous veins and the perforator veins in the ankle. Standing for long periods, obesity, and pregnancy are contributing factors. Trauma, DVT, and inflammation that results in vein valve damage are secondary causes. Individuals who must be on their feet for a great deal of time are encouraged to wear support stockings to promote venous return. Signs and symptoms of varicose veins include dilated, twisting appearing superficial vessels on the legs. Swelling of the foot and ankle on the affected leg can occur by the end of the day, and swelling will typically be accompanied by itching. Diagnosis will be made through physical assessment and patient history. Treatment of varicose veins includes using elastic support hose, exercising the legs and feet periodically throughout the day, and elevating the legs whenever possible. Prolonged standing, sitting, or crossing the legs should be avoided. Exercise such as walking or swimming can be beneficial because the muscle contraction will encourage venous return to the heart. Knee-high elastic stockings or elastic wraps can be used to support venous circulation. Exercise is especially beneficial to patients with decreased blood flow. Walking is the ideal exercise for ambulatory patients. Medications such as NSAIDs can be used for aching. Surgical procedures can be used when medical treatment has been ineffective. Small varicosities can be treated with scleropathy. This involves injecting an agent that will sclerose the vessel, causing it to dry up and wither. Endovenous occlusion using a laser can be performed by placing a catheter within the vein under duplex ultrasound guidance. A laser will heat up the vessel, causing it to collapse and close off. This can be performed in an office setting or an outpatient ambulatory surgery site. Compression stockings are worn for 1 to 2 weeks after the procedure, and patients should ambulate immediately after the procedure for 30 to 60 minutes and 1 to 2 hours per day for 1 to 2 weeks. Vein stripping can be performed for severe cases. A less invasive technique is called perforate invaginate stripping, or PIN. In this procedure, only 2 small incisions are used, and the vein is removed much like pulling a sock inside out. Chronic venous insufficiency is common among older adults. Many cases are caused by congenital absence of the valves in the veins. This can also occur when venous valves are damaged and can affect the superficial low-pressure vessels or the higher-pressure deep venous system, such as occurs with severe cases of DVT. The condition can lead to venous stasis ulcers. When valves are incompetent, venous return is compromised, and flow will go both ways in the vessel. The increased pressure will lead to leakage of red blood vessels into the tissues. The breakdown of the red blood cells will release hemosiderin. This causes the brownish skin color. The skin will also become thick and hardened. Signs and symptoms of chronic venous insufficiency include chronically swollen legs, thick brownish skin around the ankles, and itchy, scaly skin. Venous stasis ulcers will often occur. Diagnosis is made through physical assessment and patient history. Treatment is the use of knee-high elastic support stockings and elevation of the legs for 8 to 24 hours each day. Teach the patient to avoid prolonged standing or sitting and to sleep with the foot of the bed elevated 6 inches. Legs should not be crossed when sitting, and tight, restrictive clothing should be avoided. Legs should be elevated above the heart level whenever possible. Diabetic patients with venous insufficiency are at a high risk for venous stasis ulcers due to the compromised circulation in their extremities and their slow rate of healing. It is imperative that patients with venous insufficiency be taught the extreme importance of good foot and leg care. Any injury to an affected extremity, no matter how minor, should be reported to the healthcare provider immediately. Treatment for an ulcer would consist of leg elevation, a moist dressing, and compression. The dressing to be used will depend on the condition of the ulcer and the amount of exudate produced. Compression dressings are not used if arterial insufficiency is also present. Compression therapy options include compression stockings, elastic tubular support bandages, intermittent compression devices, a paste bandage such as an Unna boot, or placement of 2 to 4 layers of compression dressings. Occlusive dressings can also be used. Compression dressings can be placed over wound dressings. These dressings will help reduce ulcer pain and keep the wound moist. They will also assist with debridement. The dressing should be changed every 2 to 3 days to every few weeks, depending on the type of dressing applied. For success, the underlying venous problem must be treated. A graft may be necessary to heal the ulcer. Give the patient considerable support because treatment is long, recurrent, and tedious. A nutritional assessment is essential. Objective assessment data would include status of skin, noting color, warmth, and moisture. Assess arterial pulses and determine the pulse rate, rhythm, and character or force of the pulse. Appropriate exercise is important to treat vascular disease. A major role of nursing care for a patient with venous insufficiency is to monitor the condition and determine whether treatment is effective. Carefully evaluating pulses and comparing them bilaterally are important parts of nursing care for patients with problems of the vascular system. It is important to determine whether skin color and temperature have changed since the last assessment. Ulcerated areas are monitored closely, measured, documented in writing, and photographed to determine whether healing is occurring. Subjective data from the patient can help evaluate whether treatment and nursing actions are effective. The patient should be able to demonstrate understanding of their disease process, preventative measures, medications, signs and symptoms to report to the healthcare provider, and any follow-up care. Many patients with vascular disease are treated in outpatient clinics and in their homes. Your role in these settings is focused on ongoing assessment, coordination of care with other members of the healthcare team, monitoring progress, and compliance with treatment, as well as patient education.